If this were your 19-year-old daughter, would you knowingly give her a drug that chemically shuts down her reproductive system? That may sound extreme, but that is exactly what happens with medications commonly and incorrectly called hormonal contraceptives. Today I want to talk about contraception from a holistic and integrative medical perspective. Not religious, not political, just biology, psychology, and long-term health. I'm Dr. Fred Bloom and I practice integrative and holistic medicine. What shapes my perspective is simple. I don't just see what these medications do in the short term. I see what they do years later. Women come into my office with anxiety, fatigue, infertility, and hormone resistance. And one sentence I hear over and over again is this: I was fine before I went on birth control. A patient recently asked me what I would recommend for her 19-year-old daughter. My answer surprised her. Let me explain why. Before we talk about contraception options, we need to fix the language. Oral contraceptives are often called hormonal contraceptives. That term is medically misleading. These medications contain no human hormones at all. They contain synthetic, hormone-disrupting chemicals, foreign compounds designed to override, suppress, and block normal endocrine signaling. They're not bioidentical, they're not physiologic, and they do not support natural hormone rhythms. Instead, they shut down the body's own hormone production. These chemicals suppress ovulation, shut down the hypothalamic pituitary ovarian axis, reduce estrogen, progesterone, and testosterone signaling, and alter cortisol, thyroid, and insulin pathways. From a physiologic standpoint, this is best described as temporary chemical castration. That term is intentionally uncomfortable. In most cases, it does not mean permanent sterility. It means intentional chemical suppression of reproductive function. That is biology, not ideology. A 19-year-old woman is still developing. The brain, especially areas responsible for judgment, impulse control, and emotional regulation, continues developing into the mid-20s. At the same time, the endocrine system is still establishing lifelong signaling patterns. Introducing hormone-disrupting chemicals during this window can have lasting effects. These drugs can alter baseline hormone set points, affect mood and anxiety regulation, reduce libido and sexual responsiveness, and disrupt future fertility signaling, often subtly at first, often showing up years later. Women don't come in saying, "This is because of birth control." They say their anxiety started in college. Their libido never came back. They stopped ovulating. They can't get pregnant, or their hormones don't respond anymore. And very often, the timeline includes years of chemical hormone suppression early in adulthood. Not always, but often enough that ignoring it is irresponsible. There's another piece we rarely talk about. Sexual intimacy releases oxytocin, which promotes emotional bonding and trust. It also releases dopamine, which reinforces pleasure and reward-based learning, and vasopressin, which contributes to long-term attachment. In young women especially, repeated sexual intimacy can wire emotional attachment before emotional maturity is fully developed. When intimacy occurs without safety, stability, and genuine commitment, it can strengthen attachment to unhealthy partners, make it harder to leave unsafe relationships, and blur chemistry with real connection. This is not religion, this is neurobiology. Pregnancy prevention dominates the conversation, but it is not the only risk that matters. Barrier methods reduce STD risk, but they do not eliminate it. Protection is not 100%. Breakage, slippage, inconsistent use, and skin-to-skin transmission all matter. When pregnancy risk is chemically removed, social dynamics can shift. Some women feel pressure to engage sexually. Boundaries can erode. Power imbalances can emerge. So what do I actually recommend? My priorities are preserving endocrine health, minimizing long-term harm, and supporting emotional and physical safety. From a medical standpoint, abstinence carries zero pregnancy risk, zero STD risk, and zero hormonal disruption. It remains the lowest risk option. If a young woman chooses to be sexually active, I would recommend barrier methods, condoms, diaphragms, or the FemCap. They avoid hormone disruption, preserve natural cycles, offer partial STD protection, and are immediately reversible. They're not perfect, but they respect physiology. We also need to talk about longer-acting devices because they are often presented as set-it-and-forget-it solutions. Copper IUDs are non-hormonal, but they can increase bleeding, cramping, inflammation, and discomfort in some women. IUDs that release hormone-disrupting chemicals, such as Mirena, cause lower systemic exposure than oral contraceptives, but they still suppress normal hormone signaling. They are still associated with mood changes, reduced libido, anxiety, and many other side effects in some women. Implantable arm devices like Nexplanon continuously release hormone-disrupting chemicals. They strongly suppress ovulation. They are frequently associated with mood changes, anxiety, depression, weight gain, irregular bleeding, reduced libido, and many other side effects as well. These devices are not benign. They may be appropriate in select cases, but they require real informed consent. Before any young woman starts contraception, true informed consent means understanding what is actually happening. These drugs contain no human hormones. They suppress ovulation and shut down normal endocrine signaling. They can affect mood, libido, anxiety, attachment patterns, fertility recovery, and long-term hormone responsiveness. Copper IUDs may increase pain and bleeding. Mirena-type IUDs may still cause systemic effects. Implants like Nexplanon carry significant neurohormonal risks. Declining, delaying, or discontinuing contraception is a legitimate medical choice. Protecting natural hormone function is not irresponsible. It is informed. That is what true informed consent looks like. Not persuasion, not fear, just clarity. The real question is not what's easiest. The real question is what best protects her long-term biology, emotional health, and future fertility. Synthetic hormone-disrupting chemicals may prevent pregnancy, but they also silence normal hormonal communication during a critical developmental period. That deserves honesty before the prescription, not after the consequences. If you're a parent, a young woman, or a clinician, were you ever told these drugs contain no actual hormones? Were you told they function through chemical castration? Would that knowledge have changed your choices? Let's talk about it in the comments.